I've got my new pointer so that we can talk through what we're going to see. Oh, thanks for telling everybody hello and where you're going to be from. I see names I recognize, so take a moment to say hi if you want to and where you're at. This this case study that we're going to look at is going to talk about depression. It's also going to have substance disorders. Now, I want to bring some teaching points so you could see scenarios like this when you're testing, but there are actually F codes that you may not be aware of that we want to make a point that you are aware of so that if you have them pop up in a test, you know what to look for as far as the guidelines are concerned. All right. Yep. Thanks everybody for saying hello. Ooh, we even have somebody from Puerto Rico. So much fun. All right. So let's look at this case right now. We're going to go over it quickly, just kind of scan it. And I want to get your thoughts. You might want to get a notebook and a pencil and write your thoughts down. You can have your manual there. We are again going to just look at the ICD-10 aspect of that, the medical decision making that's involved. We're not going to do the E&M. We may come back and do that at another time and look at it from a CPT standpoint. But right now we're gonna practice with our ICD-10 since this is a student webinar. All right, so when you look at this, let's look at the HPI aspect first. We have a 66-year-old female, and it says alcohol dependence, depressive disorder, and that she'd like something for her insomnia. So why is she there? Her chief complaint, she is having insomnia, and that she has alcohol dependence, she has a depressive disorder, and the patient also self-reports depression and skin-picking behaviors. Do you guys know what that is? Have you ever heard of that before? If you have, put it in the chat. Excoriation, sites that are on her face and arms, so it's evident that it's there. All right. And let's go. Oh, she has some mild cognitive impairment. Are we going to need to code for that, right? Now, again, the HPI, don't forget that when we look at these, we divide up different components. The HPI is the patient telling the provider what's wrong with them, why they're there, and then the provider is asking questions, prompting to get kind of a feel for the diagnosis. Now, if there is already an established diagnosis, say the patient has diabetes, and that's why they're there, then there's this, routine questions that you would ask. Have you been taking your blood sugars? How have you been feeling? Da 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 da. But in this scenario, the patient is a sick visit, and the patient has specific things that they want to cover with the provider. Let's look at the past psychiatric history. Again, has alcohol dependence and a history of dependence on opioids. All right, now we're getting into the substance abuse. We are substance disorder. So the focus of this case study is depression and substance disorders together. All right. Carmen says, I seen skin picking, but did not know there was a code for it. Yes, there is. Now, I'm looking at Johan's vlog. Wow, those codes. You guys make a point to look at that because we're going to, and Johan is just abstracted really quickly. F33.19. We know F codes are, I always think of them, oh, you're feeling kind of funny, right? So, that would be your depression and substance abuse, a lot of F codes. Then we have F10.20, G47.00, R41.3. Good job. And insomnia is documented as patient reported. Very good. These are all points that I was going to go over. So kudos. Johan is going to get the gold star tonight. Thank you for looking at those. Now let's break down, because my goal is to make sure I find something that you guys did not know about. Uh, uh, yep, so I have a little doubt as to whether to code it or not. Thank you, Johanne. Good point. I was going to bring that up. Okay, now, we've looked at kind of the past psychiatric history. That's pertinent because the patient has already stated they have alcohol dependence, they have a depressive disorder, they have the skin picking, they have depression, and the fact there's other things going on in here, but we know we're going to be pulling F codes, right? Substance use history. That's pertinent. That's not going to be on most encounters. That's not something they actually ask on a routine basis. However, this is definitely for those reasons, right? The depression. So it makes sense. Patient refuses treatment for alcohol dependence and saying it is a coping mechanism for her depression. In the past, she was dependent on intravenous IV opioids, but hasn't used that in years. Okay. No noted tremors or seizures or other withdrawal symptoms. That's very pertinent because a lot of these dependence and substance abuse disorders have withdrawal symptoms built into the code. The patient smokes 2 packs of cigarettes per day. The past medical history pertinent for anterior wall myocardial infarction in 2017. So they had an MI in 2017. Mary says, our patient reported diagnosis picked up. Well, that is what one of the other things. Man, you guys are savvy tonight. This tickles me. Uh, they would not be if it's only mentioned in the HPI. So we have to go and see where it's mentioned in other areas for the provider to acknowledge it and assess it. And if there's going to be treatment, then it would be picked up. But just because the patient states it does not mean the patient has it. Very good point, Mary. All right. Then social history. Patient is unmarried, lives on her own. Mental status examination. Uh, the patient appears disheveled. She makes good eye contact. Her speech is normal rate and tone. She displays no psychomotor agitation or slowing. These are all these things to see if the patient is actively on a substance also. Mood appears euthemic. I can't say that very well, but her affect is constricted. The patient is at times tangential in her thought process. She denies any suicidal or homicidal ideations, no delusions detected. She denies any auditory or visual hallucinations or history of hallucinations because that's built into some of those codes. And her judgment and insight are fair. She has mild cognitive impairment. So again, that has been reiterated from the HPI. So this is the impression. This is where we can pull an abstract, start thinking about abstracting those codes. The patient is now notice here, the impression is somewhat repeating the HPI because the provider is acknowledging that, okay, this is where we're getting a diagnosis. So we have recurrent major depression and alcohol dependence. That is different than what we see in the first sentence of the HPI, which is alcohol dependence and depressive disorder. Those are different codes. So there we go. Recurrent major depression. When you look to code depression, they're going to want to know, is it single or recurrent? The single is the code that you use the first time the patient gets diagnosed, and recurrent would be everything after that. So F32 is the single, that first episode, and then F33 is every time after that. And then, oh, sorry, let me get this off my screen. Apologize for that. And now we're looking at alcohol dependence. Now we move to the next sentence, report severe insomnia. Very good. Now we have more of a label for the insomnia and has a history of IV drug use. So That's pertinent. Judging from the patient's current presentation, biological factors, including history of chronic medical illness and patient's history of current and past substance abuse dependence. Physiologically, the patient seems to be intact with coping mechanisms, and the patient has been able to not require inpatient hospitalizations for quite some time. That means what? That the patient's doing pretty well. The patient is living on her own, appears to be to have good resources. In terms of her decreased memory, there is a question of whether there is a component of dementia in her presentation. She's 66 years old after all, which really isn't that old, but it sounds like she's had other issues. There's certain things that age you, right? Socially, the patient appears to have somewhat supportive social environment, though there are some acute stressors present. The patient is able to live on her own. Now, I know that you guys are already jumping there. Yeah, smoking, Angela, we got that. Jackie's already said the old MI I25.2. Let's see. So Johan's put a couple more codes in. Okay, so and Belinda, you guys nailed the old MI. This is one that often gets overlooked, okay? And there could be cognitive stuff with that. We got to remember the disease process. So let's look now at the HPI. Some of these things I've already alluded to, but this is what you would do if you're getting ready to use this in a testing arena. We teach you with the BAT technique, and your test taking skills that you get with the blitz is use that highlighter, or you can use a pencil, and you start highlighting these key phrases that you're probably going to need to abstract. And we have the link up there on how to do the BAT technique, as well as in our blitz we teach you this. So alcohol dependence, depressive disorder, skin picking behaviors, because we have the excoriation sites, and mild cognitive impairment. That's what we abstracted from the HPI. Let's move on. Alcohol dependence is backed up, history of dependence of opioids. Okay, all of this is stuff, again, reiterating. Then in the past, meaning not now, history of the IV use and smoking 2 packs of cigarettes. You guys are nailing it. Very good. Okay, then we have the history, the old MI. Nailed it. Man, you guys are just on top of it. Just tickles me to death. Okay, really nothing on the social history that is pertinent, that is codable, but again, that is important for her. Cognitive shows, mild cognitive, she's able to live on her own. Mental status, the mild cognitive impairment, we're able to abstract that. Not really anything else out of there. And then recurrent major depression, which gives us higher specificity. So if I'm going to write a multiple choice off of this scenario that we're looking at, you bet one of the options, or the options is for that code, I'm going to put depressive disorder. I'm going to give a choice of the F32 code, which is the single episode, or recurrent, which would be an F33 code. This is major, so that's, it'll say mild, moderate, severe, and then they'll have other things on there. But of course, I'm already seeing things that would allow me to make multiple choice questions that could trip you up if you don't know, or not taking the time to read the code description. All right, so we got alcohol dependence and insomnia. So the assessment and plan, these are the diagnoses that the provider is stating. Major depressive disorder, recurrent, moderate. All right, so we have MDD, which is the abbreviation for that, and recurrent, meaning it's an F33 code. Now, you don't have to have that memorized, but as often as MDD is coded now, once you get out there, it's probably a good idea, in each one of the areas of the code set, in the F codes, the F32 and the F33 might be a good idea to kind of make a note for you. So if you find those in your manual in the tabular, you might just want to make a note that says F32 first diagnosis, first time diagnosis. F33, everything after that. However you want to say that so that you know that if this is recurrent, this is not going to be an F32. If that's on the multiple choice, bam, it's out, right? You can rule that out, and they'll probably put it in at least two of them. So that's like A and D. You could strike that out because it says recurrent. And then moderate, I would pick an F33 code. You got mild, moderate, and severe. This is moderate, so I would put, severe or mild as a choice. So again, this is how you look at these MDD codes. Three things. What is it initial encounter, or is it, subsequent? And then occurrence. Then is it mild, moderate, and severe? And is it in remission, right? Is there any psychotic episodes afterwards? So pay attention to the codes itself. Alcohol dependence, rule out dementia. Now, is that a diagnosis? That's not a diagnosis. That's not even a sign of symptom. So the provider is just stating, hey, there's a possibility we have dementia. So you can't code dementia, because when you see rule out, that's not a diagnosis. So don't be looking up dementia codes. And I guarantee you, if I'm going to write the 4 multiple choices, I'm going to put dementia in there. And you're going to, so if you see a code for dementia, out it goes. You can run a line through that multiple choice. Insomnia, history of the MI, very pertinent, and polysubstance abuse. What does polysubstance abuse mean? Anybody know what polysubstance abuse is? A little practice in your medical terminology and anatomy. Are you guys slowing down? I don't see you out of the corner of my eye typing those notes as fast as you had been a little bit ago. So there you go. Multiple. Mary got it. She was the first one to put in it. Multiple substance abuse. Because what are the substances? We have nicotine for cigarettes. We have opioids, even though it was in the past. We have also, opioids and, more than one. The patient does not require inpatient treatment at this time. In terms of acute stabilization, the patient appears to have no suicidal symptoms or acute symptomology. So that's good. And then it goes in to say the patient did have success with this particular medication, zolpidem, in the past, and she's receiving a 30-day prescription. So again, the plan is we're going to put her on zolpidem. Very good, right? Now, that means now we're going to start pulling some codes, Now, I may say your name wrong. Gaithry, multiple use of illegal drugs. It could be, but it doesn't have to be illegal because cigarettes are not illegal, right? So, again, alcohol's not illegal, but it's considered a substance. And now Johan just brought up a point that says, but documentation says history of drug use, right? But what are the substances? It's a history of opioid abuse, but she's still taking alcohol, which is, I think, F10, and cigarettes, I can't remember. I think that's F17. I can't remember off the top of my head, right? So, yeah, exactly. So again, we're going to now look at the diagnosis codes, the diagnoses that we can pull from this. The chief complaint is insomnia. That's what brought her to the provider in the first place. What's the occasion for the encounter? That's the way they phrase it, which is a little wonky, but what's the chief complaint? Why did she go to the doctor? She's having insomnia. But there's actually a catch to this. It's not just insomnia. There's more than one type of insomnia code. And this is where I think I've been able to trip you up. because all of the codes that you guys have been swinging out there so far, you're doing really good, but you haven't nailed the insomnia code correctly yet. Okay, and I'm going to show you why. F10.282, alcohol dependence with alcohol-induced sleep disorder. Did you know that code even existed? How many of you knew that there was an insomnia that was associated with alcohol dependence? I'm going to guarantee you probably none of you guys were aware of that. So if you were aware of F10.282, or that even crossed your mind while we were talking about this is actually the highest specificity for the insomnia. Jackie says you thought of that? You knew? Jackie, you're telling me that I didn't trip you up? Okay, well, that's okay. Good, Jackie. I'm glad. Anybody else? Did you see that coming? The F10.282. And it's okay to say no, because I really didn't expect you to see that or realize that that code existed. But we want to make sure that we are coding to the highest specificity. So just to code insomnia is not going to get it in this case. All right, nobody else is fessing up to realizing that there was a different type of insomnia. It was alcohol dependence with alcohol-induced sleep disorder. And Mary says, so you don't need, due to combining them. Yeah, okay. This is the case. So the coding tip, the patient's insomnia in the documentation was linked to the alcohol because of the word with. And you go to the alphabetic index and you're looking at with. So here's the meat for that. And really, we've already gone over it, but right here, alcohol dependence, depressive disorder, and she's got insomnia. So those are linked. Then we see the patient again has alcohol dependence. Patient refuses treatment for alcohol dependence. Okay. And she reports severe insomnia. So again, your knowledge background of the disease process, alcohol dependence, and the signs and symptoms that go along with it would allow you to get to the highest specificity there. Impression, judging from the current presentation, and we'll skip here, medical illness, history of current and past substance abuse and dependence. So that's the impression. AMP, zolpidem in the past, and that means you need to be aware of what that medication is used for, right? And that is important. We're going to talk about that in the future, of the importance of your pharmacology background that will help you with these codes. So F33.1, not 332, or excuse me, 32, because that's the single one. We know this is recurrent. Is MDD recurrent moderate? So it's a 0.1. And then depression, F32.9, or even F32A, that does not risk adjust, but major depression not otherwise specified, F32.9. And again, we always have that component of risk adjustment, because I love that. And so the meat for the MDD is depressive disorder. And then we've got it here, depression. And then here, recurrent major depression and then the excoriation or the skin picking disorder is F42.4. That is with the meat we have here. Self-reports depression and skin picking behavior. That's in the HPI, but we have more. Excoriation sites are apparent on her arm and face. Now, it's in the HPI, but he sees it. She said, I'm picking. And then he reiterates in the HPI that he sees the excoriation sites. And if there was a physical exam, that would show up as well. It does not seem to be infected. So again, that's from the provider's perspective, even though it's in the HPI. All right, we're not done. G31.84, mild cognitive impairment. Let me look and see if you guys got that one. G47.00. I have to, Johan, you'll have to tell me what that one is. I don't have that one memorized. HPI for that, mild cognitive impairment and decreased insight into her history, meaning, mild cognitive impairment. Mental status exam. And this word right here means the same thing, tangential. And then we have mild cognitive impairment in the mental status. It's just all over the place. The impression, it's all right there. Decreased memory. There's whether it's competent, a component of dementia, not sure. Then our old MI, you guys nailed that, I25.2. You know what? I would go ahead and memorize that one. I'm really good about telling you what you need to memorize and what you need to be aware of. So that insomnia due to alcoholism is not a code you need to memorize. Do you need to be aware that a code like that exists? Absolutely, right? Because those are the type of things that they're going to test you on. However, that you don't have to you don't have to memorize that. Knowing that F32 and F33 are different and why they're different, that you don't have to necessarily memorize it, because you can put it in your book, right, and make a note. But I25.2, I would memorize that. It's not hard to figure out a way to come up with, that you could memorize it. I can't think of off the top of my head any cute little things to remember that I25.2 is an old heart attack, but they have MIs and old MIs a lot in your testing questions. And if you go in and you look at a test question and you can look at the codes first before you even read anything and get an idea of what they're going to ask you about. So if you see I25.2 on usually two of your choices and it won't be on two others, then what I'm going to immediately go do to rule out two of those options is go abstract real quick. I'm not going to read it. I'm just going to look, is there an old MI? And we know the key words, past MI, more than 4 weeks ago, et cetera, et cetera. And when you find that, and if it is applicable, if that's true, it's an old MI, then you're going to circle it, and then you're going to look down and say, look, I see an I25.2, which is an old MI, and on two of the questions, and two of them don't have that, so I'm knocking, A and B off because I25.2. Now you only have to look up two questions, right? You've already ruled out two. So I25.2 is just as important probably as I10 for your hypertension, right? Very, very common. All right. So here is a coding tip, is that for old or healed myocardial infarction is also another key word. You can always use that code. It's almost always applicable for whatever scenario that the patient's coming in for. So the meat here is the past medical history. That's all we need. It has to be in there. Then for nicotine dependence, uncomplicated, I17.210. I'm not sure if any of you guys had mentioned that one before. But that's okay. So the meat for that, substance use history. They're smoking 2 packs of cigarettes a day. That's all you need. And then F11.21 is opioid dependence in remission. Now, I know some of you were thinking, how am I going to do that? Is there a code for a history of opioid dependence or what? Really, actually, we have opioid dependence. She's still dependent, but it's in remission. What's the meat for that? What tells us that that is what we need to do? For a personal history of the IV dependence in remission, you go to the index. You look up history, personal, not family and all that. You look up the drug dependence, and then it tells you the drug type, opioid, and then in remission. So that's how you look that up in your index. Then we have here history of dependence on opioids. So the index tells you that there isn't a code for history of opioid use. The proper code when you look up history is to use the remission. And then again, we see was dependent on IV opioids. And then the impression, patient's current presentation that they are not using any more that they could justify or say in there. Very good. Any questions about what we looked at tonight? Johan says, but insomnia can be coded here, Alicia, to document the type of sleep disorder. You could put the G4 7.00, but actually the highest specificity is what you're going for. So we're going to use that other code. Why is she not sleeping? Right? Because of the alcohol use. That's the highest specificity we want to get to. She has a sleep disorder. It's insomnia, but there's nothing there that tells you that if you use that alcohol dependent sleep disorder to go ahead and code insomnia, right? Now, if it said that, then you'd go code insomnia as well. Jackie says, how can someone contact you directly? Just send a message to cco.u or helpdesk@cco.us and or join the club. The CCO club is cco.us/club/club. I can't remember if it's forward or back. But anyway, you can go to the cco.us club, and we have a forum, and for a minimal amount every month, you have access to myself. You can ask questions, and you have all of our coaches and our whole entire CCO team out there helping you. That's kind of like instant messaging. That's the best way. So cco.us/club. Can we add G47.00 on top of F10.28T? You can. Yeah. I mean, it's not going to hurt anything if you do, right? You're clarifying that. So Mark's asking, if you can. I'm not saying you don't have not to, but absolutely it would do that. Yeah. Mm-hmm. You're welcome, guys. Any other questions? If not, again, when you're in the CCO club and you're our student, you get to go back and have this transcription, you get the slide deck, and you get access to all of us talking about it. So Jackie says, I'm a QA coordinator for HCC coders. Very good. Everybody may want to write down Jackie Ferguson's name, because she may be a person that you could contact for a job. I am an insane nut for risk adjustment, because it's all about the disease process, right? And that's what I'm passionate about. So this is kind of looking at everything from a risk adjustment standpoint, in addition, because we're doing ICD-10. I hope this was helpful for a student webinar, and feel free to carry on the discussion in YouTube, but better yet, go out to the CCO club. Don't forget to give the thumbs up, you guys. That really helps us. So if you've enjoyed this and you think this is helpful information that we're providing to you free, then that helps. And you can share this content as well. Okay? All right, guys. Thank you very much. We'll see you next time.
Do you need more medical certification and business training? Learn more at www.cco.us.